Hi, my name is Stuart Winkler, and I'm a GYN Oncology Fellow at Walter Reed. And I wanted to give you guys a little talk today on techniques and the use of surgical tools. This is something that I think is really helpful, particularly for first and second year residents, but we can all use a refresher with this from time to time. The primary book that I'm going to be drawing from is a book called Technique and the Use of Surgical Tools by Anderson and Romph. This book is a few decades old now at this point, but it has a lot of great material in it. And so I've taken some images from that book and have elaborated on some of the points that the authors make. So just to start off with, I want us to just sit and think about surgery and think about it as a performing art. When you are practicing for an instrument, for instance, so if you're a violin player or a pianist, or you're doing a certain skill in sports, practicing each step is just as important, if you're a surgeon as it is if you're a pianist. And then practice makes perfect is something that we say often, but it really can deteriorate into practice makes imperfect with the repetition of mistakes. And so, like my dad said, my dad's a piano teacher, and he used to always say, practice makes permanent, not necessarily perfect. And I think that's very true in the OR. So when we think about a well-planned operation, it's composed of definite steps, each thoroughly practiced until securely performed, and it will result in a well-executed surgical procedure. And when you're thinking about getting better and better, the byproduct of that is speed and ease in the operation. And it's a byproduct of accuracy and security, and ultimately a byproduct of practice. So today we're going to talk about instruments and the use of surgery, and it's the basic instruments. So we're not talking about staplers, we're not talking about specialized instruments, but really sort of the basics. So the scalpel, the scissors, needle holder, forceps, surgical clamps, and retractors. So starting off with the scalpel, there's a couple of different grips that we commonly use. There's the pencil grip and the violin bow grip. And I have a little disposable scalpel here that I'll kind of use to illustrate. So for the pencil grip, we often will use this pencil grip for making holes for laparoscopic ports, for instance. That's one of the common reasons that we use that pencil grip. Or if you're making short incisions, you can think about, you get a lot of the control for the pencil grip from your fingers, from your first finger primarily. When we talk about making longer incisions, we typically approach that with a violin bow grip, and that gives us more depth control. So as we make the incision along the incision, we are able to control the depth of the knife better using what we call a violin bow grip, which is holding the knife on the sides. There's a couple of different cutting techniques that we use as well. So there's slide cutting, and this is where the blade motion is at a right angle to the scalpel pressure. And this really provides us with precise depth control. And this is the primary type of cutting that we use for our longer incisions. And then we have press cutting. And in this type of cutting, the blade motion and the scalpel pressure are aligned. So this is more for your stab incisions, like I said earlier, for laparoscopic ports, and it often goes with a pencil grip. There's also scraping and shaving techniques. We use that sometimes with cytoreduction. And there's sawing techniques too, sometimes if you have to use to get through tougher tissue or a scar. So when it comes to making the cut, just always remember that an incision is the patient's permanent reminder of the surgeon's skill. And so we want to prepare for that. By the way, throughout this entire book, there are lots of these little surgical aphorisms. Some of them are kind of cheesy and old, but I've included some of my favorites in this talk. So we first want to plan, and we want to compensate for any skin distortions or curves in the patient anatomy. And then most of the time we want to mark the planned incision. And so we'll use an indelible marker to mark the patient's skin. And it's important that it not rub off with the prep. And so you want to use, typically the marker has two ends, one of it is more of a permanent side, and the patient won't mind too much if that marker is still on her skin in a couple of days, but she will mind if the incision's crooked. So do what you need to do to plan your incision. And then make cross hatches as well. And this helps when you're reapproximating the skin at the end, whether you're suturing or stapling, it helps to reapproximate the skin in the right way. And then when you're making the actual cut, you want to stabilize the skin. And don't distort the skin for yourself, and certainly don't let your assistant or your attending distort the skin for you. You want to sort of think about the vectors when it comes to this. So I often will use my non-dominant hand, which for me is my left hand, and I will, sort of as this little illustration shows, will provide tension for myself. It's easier for you to tension for yourself rather than trying to coordinate even tension with your assistant. Tension for myself, and then when I make that cut, I make sure to go to my fingers but not past them. And the reason is, if you think about the vectors, if you're going past your fingers when you're making your longitudinal cut, you're going to bunch that skin up before you hit your fingers. So you really want to start where the tension is, where you've started with your non-dominant hand. And so when you think about the force vectors, it kind of makes sense why you would do that. Another very important thing with incision is depth control. Ideally, you want to incise the skin completely with one motion. And these little histology images from below show that when you cut through the complete epidermis and dermis with one incision, you're less likely to have this peak and valley effect, because no matter who you are, no matter if you're the most perfect surgeon in the world, you're not going to, across that entire linear incision, be in the same exact plane and right in the furrow that you were in with your original incision. And so this really does help when you're closing at the end, particularly if you're suturing the skin, be able to get that skin approximated well. A common mistake for a new intern is to not push hard enough, but it's important to try to get through that skin completely with the first pass. So one aphorism that I think is helpful here is, when driving a car, we watch where we're going, but when making an incision, watch where you've been. And people often don't talk about this, but this is how you master depth control, is you really kind of focus on the cut that you just made to help adjust the depth of your hands. So as you're cutting, your eyes are just behind where your knife is, and you're looking at where you're going within the periphery. And if you have a marking, as you should, it'll tell you right where to go, and it's not hard to stay in your line. But you really do want to pay attention to the depth of the incision that you just cut. When it comes to making a turn, like around the umbilicus or any sort of a planned turn in your incision, it's important to skinny up the knife by coming at it at a more perpendicular angle. So if you think about the belly of the knife here, it's a long belly of the knife, which is great for a long incision. But as you come around the corner, you actually want to come more perpendicular to the skin, so that a more narrow portion of the knife is contacting the skin. It makes it easier to make those turns. You're able to pivot more on a smaller part of the knife than you are on the wider part of the knife. Ideally, you don't want to stop in the middle of a turn. And then particularly, just one tip with the umbilicus, you want to leave some fat on the umbilicus for a more even repair, so that your umbilicus doesn't invaginate. And you always want to leave some fascia to sew to at the end. So when you make your incision, you can help yourself out a lot if you think about the end of the procedure and how you can help yourself. So that's kind of a brief introduction on the scalpel. Next, we'll talk about scissors. And there are really three force vectors with cutting when you use scissors. There's a closing force, there's a torque, and then there's a shearing force. So this is important because the wider the scissors are opened, the more the more your blades come in. If you think about it, if you just think about the extreme here, if you open up your scissors really, really wide and try to cut like this, the blade of your scissor is actually pointing more. It's going to be perpendicular to the direction of the blade, but the force is going to be pointing really straight out away from this. And when you have a really obtuse angle like this, you aren't really able to get that closing force. Now, the other extreme, if you have an extremely acute angle, you can think about the force of these blades, again, at a perpendicular angle, but they're pushing into each other. And so you have the benefit of using all three of your forces. So your closing pressure, your shearing force, which is the blade on blade force, and then the torque, which is, you can think about torque as what you do with your thumb naturally with a right-handed use of scissors. So you're pulling in with essentially the bottom fingers, pushing out with the thumb, and that drives the blades of the scissor closer together, and results in more torque forces. So we'll talk in a minute about how to cut with your left hand and how you have to make up for that. So if you cut closer to the fulcrum, you're going to get a stronger closing force, but you're going to tend to push the tissue out. And so for delicate tissue, that's why we cut at the tips. And then oftentimes you'll cut more towards the fulcrum for tougher tissue. So if you've been operating for a little while, you've probably figured that out, but I just wanted to go through the vectors there to make you think a little bit more about why we use scissors that way. And just remember too that all scissors are optimized for right-handed use. And that's because the top blade, which is controlled by the bottom part of your fingers, is optimized for the fingers pulling in and the thumb pushing out. There's a couple of different grips on the scissors, but really the most useful one is what we call the tripod grip. And so it's the grip where you use your ring finger in one of the finger holes and your thumb in the other hole. And then you have the ability to use your index finger up near the fulcrum for more stability. So this is the tripod grip. These scissors are obviously a little bit large. They were the ones that were peel packed in the OR today. But it allows you to keep your finger on the fulcrum for more scissor control. And really, there's not a whole lot of variation with your forehand use of scissors. Now, so there are times when you'll be using your right hand and you need to use your left hand to cut. There's a few different ways to do that. One is to intentionally think about reversing those natural pulls. So, in your right hand, you're going to pull back with your fingers and push with your thumb. In your left hand, you're going to have to actually do it the opposite way in order to drive those blades towards each other. So you can do that, and I would recommend practicing that outside of the OR if that's something you want to do. The other way to do it, occasionally you'll see people backhand scissors like this. So you would cut with your left hand, but the scissors are back, or the blades are facing towards you as you cut. I don't recommend doing that on your first day with somebody in the OR. It'll look like you're showing off, but it is something that can be helpful. And then the another thing to just make sure you read the room before you do it, is to cut with your kind of no finger grip with your left hand. So with that, I can try to show you that your thumb is going to be pushing down, and your fingers are going to be pulling up as you cut with your scissors like that. So that is another way that you can cut with your left hand. Again, if you're starting out in the OR, the best way to do it is to either use your right hand or use your left hand and try to intentionally pull back with your thumb and push out with your fingers. So you should almost always use the scissors with your hand pronated or palm down. And this is because of the way your elbow works. Because of your elbow, adjustments while supinated can only occur by pronating or being awkward by pushing your hips to the right and raising your left foot off the ground. So what that means is if you're cutting, I'm going to reposition this just a little bit. And actually, this is a little bit large, so I'm going to use these Kelly clamps and pretend that they're scissors. But if you're operating with your palm down, you can put your elbow out. So I'll show you. You can kind of flail your elbow out in order to overpronate. And then you can do full supination. But if you're operating supinated, the only way you can pronate, but the only way to supinate when you're already supinated is to drive your elbow into your body. And that's not an effective way to operate. So this is why we very rarely operate with our palms up. There's not a good reason to do that unless you're sewing on the ceiling. And so always cut with your palm down as well, and it gives you just a lot more flexibility in your wrist. And then you'll notice when we come to especially with the needle driver, there's a lot of things that you can do with your body that are awkward. And just remember, if it's awkward in surgery, it's probably wrong. There's probably a better way to do that to help, to be a more efficient surgeon. So a little bit more about the scissor technique. So there's at least 3 different types of cuts. There's scissor cuts, which is what we typically use, cutting suture or cutting tissue. There's push cuts, and so you'll use this sometimes. I mean, the way we use it probably the most is when we're putting on wound vacs afterwards, to the 1-2 paper that we cut. You can start your cut and then use the scissor to push. You can also do that with peritoneum as well a little bit. And then there's chew cuts, which are not ideal, but sometimes, like with a hysterectomy, when we're getting the cardinal ligament, you end up having to kind of use the scissors almost more to chew through the tissue for the really thick tissue. Or if you have dull scissors, everything kind of turns into a chew cut. But ideally, you want to either use a scissor cut using all 3 vectors, or that push cut. With a push cut, you often have to start a little bit with a scissor cut. You need a little bit of closing force to get the cut started, but then you can just use the force of just the sharpness of the scissors to get through the rest. A couple more things about specific techniques for scissors. So when you're suture cutting, the practice of rotating the scissors to serve as a spacer to create short uniform free ends seems like a good procedure for those with weak eyes or poor hand-eye coordination. You'll see people do this where they'll put their hand in there and then they'll turn the scissors, almost all the way up and then make the cut. And the idea is that you're using one of the blades as sort of the spacer. Ideally, you don't need to do that. I think the biggest thing when you're making cuts, typically it's going to be the most junior person assisting. You want to be prepared. And so the way you do that is you come in early and you don't rush the cut. So when somebody is tying down, if they're, to knot number 2, that if it's vicryl, they only have a couple more to go. You should already have those scissors in your hands. And usually around knot number 3, I'm already coming in. So, if I'm coming in and cutting this pen, I'm already coming in and I'm right there and ready. And that gives the attending the opportunity to say, oh, no, we want to hold this with a hemostat or whatever. And then if not, you're right there, you can make the cut. And it's not like you're trying to bring the scissor in at the last minute and making jerky movements and such. So you want to have that ready for you. Something that you can do, particularly if you want to just own the scissors for the case, when you're holding your scissors, you can actually flip it up on your ring finger, and you can still use the majority of your fingers to hold the suction or assist or whatever you need to do. And that way you can have your scissors sort of protected and nobody else will grab them. You just have to make sure the scrub tech knows what you're doing. One other way to use scissors is to use them with blunt dissection. And it works well unless the force needed to separate the adhesions is greater than that needed to separate the tissue. So typically in unscarred tissue, blunt dissection with the scissors works really well. And that's because if you're working on the bowel, for instance, kind of the integrity of the bowel will actually help keep you out of trouble. It doesn't work as well with scar, and that's why oftentimes we need to use sharp dissection when we're encountering scar, because you don't want that force to separate the scar to be greater, and then you would end up tearing through the intact tissue. A couple other things that we do, we can use scissors to undermine. If you're, for instance, doing a vulvectomy and you're trying to get a little more vaginal length for closure, you can mobilize the posterior mucosa using scissors to undermine. There's a lot of different ways that we can use scissors to help us with planes. So they're really one of the most important instruments that we have. So we'll move on. We've talked about scalpel, we've talked about scissors, and now we'll talk a little bit about the needle driver. And so I think this is one of the most important parts of this talk, and this is something that you can do next time you're in the OR to help improve you as a surgeon. And that's to avoid what the authors of this book call stuttering and stammering. And so stuttering, the way they define it, is things that happen before you throw the stitch that are inefficiencies. And so things like repositioning the needle after the scrub tech is loaded it, repeatedly going in and out of a wound to reposition the needle tip on the incision before taking a stitch. And then stammering are things that you do during the stitch. So multiple pushes near the base of the needle as you kind of like choke the needle up towards yourself before you pull it out. Multiple applications of the needle holder when withdrawing the needle from the tissue, and then sort of these superfluous motions when drawing suture through the wound after taking a stitch. So to fix this in yourself, you really need self-discipline. It helps to video yourself. It helps to have an upper level or an attending who can help keep you accountable for this. But when you're first starting and trying to avoid these stuttering or stammering habits, the best thing to do is just to slow down. So slow down, be very intentional about your moves, repress the desire to repeat a step, and that really can help you a lot. So I'd encourage you to do that. We'll kind of go through the process of throwing a stitch. This is really one of the ways I think most of us can improve our efficiency in the OR. I'm now like a PGY7 and still have more to learn with this as well. So the first step is to tell the scrub tech exactly how you want the needle loaded. I don't think we do this enough, and especially as lower level residents, we don't always feel like we have the agency in the OR to be able to do that, but it really is important. Or the first time the scrub tech hands the needle to you, you can say, for future, I'd like the needle loaded just like this, right at the tip and on a tilt. So, sorry, this is a little bit out of order, but this is just a reminder again about the stuttering and stammering with a needle holder, that it can be as comfortable and as bad of a habit to a surgeon as saying is to a conversationalist. So I think a lot of us, especially any of us that try to do some public speaking, have a lot of verbal tics that we tend to try to squash out. And as surgeons, we can have these habits that we need to work on exercising as well. So again, positioning the needle. So tell the scrub tech exactly how you want the needle positioned. For most of what we do, you almost always want the needle loaded in the middle. So they're kind of at point B. Now, if you're in the sub-Q and maybe it's a fluffier person and you want to try to get that needle to work a little bit harder, you may be able to load the needle back a little bit further, like illustration A there. Or if you're in really, really tough tissue, tough scar, you may want to choke it up towards the tip more so you have more control at the tip. But for most applications, you want the needle loaded right in the middle. And there's good geometric reasons for that. Most of our needles are in a half circle, and that really gives you the kind of the maximum ability to use the needle while rotating on its axis. And that's important in delicate tissue. And then, so there's where to load it on the needle, and then there's the position of the needle. So a lot of times, if we're working in the deep pelvis, we want that needle loaded at 45 degrees. And that allows us really to get sort of deep behind the clamp if we're trying to tie a pedicle. A lot of times for the skin applications or for things where we're not in the deep pelvis, we want that loaded perpendicular. And so just communicating that with your scrub tech is really important. So needle driver grips, I think, is one of the most important things as well. And I don't know that this is always explained to us very well. The thenar grip or palming is really the most useful grip. And it's not just because of the quickness of being able to take your hand, in and out without having to use the finger holes. That's certainly part of it. But I really like this little illustration here that kind of explains how when you have the thenar grip, you can think about your wrist, your hand, and your needle driver all being in one single axis. And so you're able to sort of rotate that through, and it really stays on one axis. Whereas if you have your thumb and ring finger in, you can see that as that cone to the side, you really have your axis coming off at 20 degrees or so, and then a separate axis for your needle driver. Now, our bodies are smart; they can overcome that, but you just have to be conscientious of the fact that if you're turning, it's not a true pivot on a point like it would be with the thenar grip. And so there is some benefit there, particularly in really delicate tissue where you don't want to shake the needle. I think that, or if you're, sewing on a vein or something like that, obviously usually we use Castros or something, different needle driver for that. But if you're sewing on something that's really delicate, you want to think about trying to line up your hand, your wrist, and your needle driver. So I think that's kind of a helpful little illustration. For women in the OR, I know sometimes, from residents that I've had, they have said it can be a little bit harder sometimes to do that palming grip, but one of the best surgeons I know wears a size 5.5 glove, and she's absolutely able to do it with some practice. So this is not something you should practice first in the OR, but this is an easy thing you can practice on your own outside of the OR. So we talked about talking to the scrub tech about the grip, and then what do you do with your needle, with the free end of your suture? So the idea here, you can either pass it to your assistant or have it trail to your right. The idea is that you don't want to sew, you don't want your the tail of your stitch to be on your right. That doesn't make a lot of sense for a lot of what we're trying to do, unless you're trying to lock it for whatever reason. But you want that tail to tail off to the right, and that'll keep it out of your way, and it will help your efficiency. And then you want to rest the needle point on the tissue right where you want it to enter. So that's important here, and you really want that needle point to go in perpendicular to the tissue. You don't want it to skive. You want to get that full thickness of the tissue. It's important on fascia. It's certainly important when you're closing the sub-Q. And again, you always want to start with your palm down for the reasons I explained earlier. And sew with the needle perpendicular or towards yourself to avoid an awkward position. So you can turn your body, but you don't ever want to be in a situation where you're driving your elbows towards your midline. You really want to come at the tissue from really opposite ways. And that way you can use your pickups and you can use your needle driver together to help you. If you're trying to sew, if I have a linear incision in front of me here, let's try this. If I have a linear incision here in front of me, what I want to do is I want to start here and sew this way rather than turn my body here and sew this way. And that just makes intuitive sense, but you'll be surprised how many times you'll be in the OR and usually the person who's sewing realizes that he's being awkward, but maybe doesn't know why. And so that's something that you can do to just help set yourself up better for being able to suture better. And then as you approach the wound with that needle, you almost want to say a mantra to yourself, which is, I'm going to place the needle point exactly where I want to the first time. I think this is important. We all have a tendency to try to make things perfect, but slow down, put the needle right where you want to put it the first time. As far as the actual drive goes, there are two forces. There's the driving force, which is really just a single vector from right to left for a right-handed surgeon. And then there's that rotational force, which is intrinsic to the needle. And you have to think about these two forces. So if you're driving a curved needle, you have to know that there's a rotational force that's going to push that curve up and towards you, or away from you if you're sewing kind of more vertically. But that's important to know where your needle is going to end up. And then the release and regrasp is the next thing. And this is really the most difficult thing to master. So that release, I think, is helped if you learn the palm grip. If you are doing the finger and thumb grip, that's okay, but you just have to realize there's an extra step in that of taking your fingers out if you choose to, or being limited in how much you can move your hand. And then, so when you're taking the needle out of the tissue, there's a couple of options. You can either use the forceps, or you can regrasp the needle, right? So we'll use forceps usually in our left hand, and what we can do is especially if we have forceps that are designed to pick up needles, you can put the needle in, pick it, stabilize before you let go, stabilize the needle with your left hand, then let the needle go, then pull it through with your left hand. So you ideally, so I should have said this, you ideally want to try to grab the tissue if you can. So if you're using particularly like tissue forceps, the ones with teeth on it, it's best actually to hold the tissue, have the tissue stay steady, drive the needle through, release the needle, it'll stay where it is because you're holding the tissue, then re-grab the needle with your palm down, and then supinate to pull the needle out. The other option that you can have is to try to just grab the needle out in the middle, where you would have it to do your next throw. I think the problem is we try to do that often, and what ends up happening is it's not perfect. We try to throw the next stitch, and then we realize we have to reset the needle anyway. I would encourage you, especially when you're starting out, it doesn't take that long. Just throw the needle, take the needle out of the tissue, grab it, reset the needle, and then stitch again, rather than trying to grab the needle out of the tissue in a way that is perfect and ready for your next stitch. And it'll help you with your efficiency if you do it that way. So again, we're kind of going through these 10 different steps. So we've driven the needle through, we've released the needle without changing the grip. With your pronated hand, like I said, palm down, grasp the needle for extraction, then supinate your hand, and then pull the right amount of suture through and hand that suture to your assistant. Again, try to keep that suture out of your way, or if you're doing a figure of 8, hold that suture in your, oftentimes you can hold it in your hand. It'll help you pull up on the tissue. And then reposition your needle on the dropper once before taking the next stitch. Don't sit there and play with the needle over and over. A couple of notes on needles. Most of you guys know this stuff, but there's a tapered needle, which we use in unscarred or delicate tissue, certainly on things like vein walls or any delicate tissue. We only use tapered needles. A cutting needle is useful in thicker tissue like dermis, and that is usually going to be a reverse cutting needle, so that the sharp part of the needle is going to be on the back side or the convex side of the needle. There's blunt needles, which we use sometimes for things like liver, or there's actually some evidence that it can be used during C-sections to help decrease the risk of needle stick injuries. And then there's something called a Keith needle or a straight needle that we'll use sometimes for straight incisions. I like that needle a lot. It's kind of beyond the scope of what I wanted to talk to you guys about today, because there's some unique techniques with that one, but just kind of a brief review of needles. So the next instrument we're going to talk about is the forceps. And I think the forceps, there's really only one good grip for this as well. The whole point of the forceps is that it's an extension of your forefingers and your thumb. And so really the best way to hold it is really sort of a pencil grip. If you have a palm grip, you're really limited because it just requires too much wrist flexion to be able to use. And so, if you're sewing on the ceiling or something, it might be useful. But for the most part, you want to use pencil grip. And you'll be surprised how many people will do kind of this overhand palm grip. I had an attending in medical school who used to whistle the Oscar Mayer Wiener song whenever he would see a resident or medical student holding the forceps this way. So there's probably nicer, gentler ways to correct, but it's certainly memorable for me, and I always hold the forceps correctly. And really using your forceps is the way to make you the best two-handed surgeon. And so I think when you watch really excellent surgeons, really efficient surgeons, if you just focus in on the use of their left hand and the use of the forceps, I think it's really helpful. And it just can be used in so many different ways as well. So we use it for stabilizing during suturing, which is sort of what we talked about before. So you grasp the tissue just outside of where the needle will enter, as long as you don't distort the tissue. And then sometimes we use it to retrieve the needle as well, particularly if there's little, like with these smooth pickups that I have here, particularly if there's little blanking on the word, but you know what I mean. Not fenestrations, but like corrugations on the inside of the pickups that can be used to help to grab the needle directly, just as long as you don't dull the needle, and use your forceps in the same way that you would a needle driver. Follow the curve of the needle. Don't try to pull the needle straight out of the tissue, or that's traumatic to the tissue. The other thing, sorry, before we go on to surgical clamps, one of the best ways to use these DeBakey's or these forceps is don't ever forget that you have the back of them as well, and you can use the back as a little retractor. Sometimes that can be really helpful. So I use these a lot, and I use them in a lot of varied ways. Especially as a new person, you'll find like kind of your instrument that you end up kind of loving. I think I found mine were DeBakey's pretty early on. That was the thing I felt like I could be most useful with. Some people call it a DeBinky because it's like a thing that a baby surgeon relies on, but I think that having good use of pickups or forceps are helpful for you. So on to surgical clamps. Just to talk a little bit about hemostats and how we use them. This is a Kelly, but you can kind of pretend it's a hemostat. So we can, and a lot of this is a little bit historic because we tend to use so much electrocautery now. We don't often tie vessels as much as we used to. But if you're thinking about a vessel, there's a couple different ways to clamp it. There's tip clamping, which avoids surrounding tissue. You could then tie around the tip of that. And then there's jaw clamping, which is the side of the hemostat, or oftentimes a right angle. We'll use right angles for this, and then you can do a 2-0 silk or a free tie around that to secure the vessel. And then the nice thing about hemostats is you don't have to tie them at that time. You can leave that on the vessel if you need to and control your bleeding, and then come back and tie. I'd be remiss if I didn't mention Howard Kelly, who is the surgeon for which the Kelly clamp is named. It's probably the most ubiquitous tool in the OR. And so he was a gynecologist. He was one of the big four founders of Johns Hopkins, and really was influential in the formation of GYN oncology as a specialty. It wouldn't go on to become a specialty until almost 4 decades after he was in practice, 3 or 4 decades after he was really in the thick of his practice. But a lot of the work that he did with urology, the textbook that he wrote called Operative Gynecology in 1898, which really kind of became the basis for Tillen's gynecology, were certainly big influences in the field. And he was really one of the first to use radium as well to treat to treat cervical cancer, and at one point had the largest collection of radium in the United States in Baltimore. So an important person to know, and I think we throw his name around a lot in the OR, but you should know at least who he was. So other things about surgical clamps, just a couple of things on free ties. I think it's important to remember that when you're tying a free tie, I'm sorry, I don't have another hand, but when you're tying a free tie, typically or a tie on a pass rather, the scrub tech will hand you the tie, or should hand you the tie at the end of the clamp. So it's kind of continuously coming out of the clamp, and that way you can use this as an extension of the suture to pass it around a right angle or whatever you're trying to tie off. And always remember to pass the passer. So if you have, if your tissue is being held, you want to pass the passer around the tissue and then use the tip of the passer to go under that vessel you're trying to tie. And then, which I'll just make one little mention of something called ligating a pedicle on continuity. The most common way that you would see this done, or the most common reason we would do this in GYN oncology, is for an open radical hysterectomy when we're securing the uterine artery. And so you want to undermine that vessel with a right angle, make sure that you have a fenestration underneath there, that it's clear underneath there, and then you pass a taut ligature through the jaws of the right ankle that's shown there. So you have a tie on a pass, and then you let go and you pass that tie underneath, and then you pull that over to the side and then can repeat again. Some people get cute and pass two ties at the same time. You can do that if you want, but that's the technique for tying a pedicle in continuity. I just thought I'd mention too, just a couple of tips on controlling hemorrhage. There's this great quote from this book that says, "Hysteria is not a useful adjunct to hemorrhage." And I think that's true. I think if you encounter massive hemorrhage in the OR, you as the surgeon have to be the calmest person in the room, and that will instill confidence in your OR staff and really get the patient taken care of. So the first thing always to do is apply pressure, and you'd be surprised how many times you can even have a pretty major vessel injury. You apply pressure, and then by the time you've gotten the equipment in the room that you need or called for help, 10-15 minutes later, that bleeding is gone. You want to establish optimal exposure so you can work around that pressure that you're holding to try to expose the vessel better. You want to clamp both sides of the vessel, and you can use either like rubber-shotted clamps or bulldog clamps or some special vascular clamps if you need to, if it's an important vessel. And then you can either cauterize or clip it, or if it's a major vessel, suture it with Prolene. But of course, always call for help if you need it. But I think the biggest thing for new surgeons is that reminder just to be calm and to be a good team leader. A couple more things. We just have a couple slides left, but retractors. There's dozens of different types of retractors, but just talking about the principle, gaining optimal exposure for yourself is incredibly important. And if the operation was difficult, chances are your exposure was poorly planned and executed. And so one of the biggest components of exposure is the incision. So I think sometimes we try to do too much through too small of an incision, and just remember that incisions heal from side to side, not end to end. Obviously, we want to try to make the incisions as small as we safely can, just for patient comfort and healing and all of that, but sometimes you just need to extend the incision. For retractors, there really are a couple types. There's the self-retaining and the handheld types. And then, like I mentioned before, you can use unconventional things for retractors, the backup pickups. Sometimes actually the finger loop end of scissors can be a really good retractor. It almost looks like a sweetheart. It work well to hold the bladder back. Just make sure that you don't sew the scissor in. You can use your sucker. It's a great retractor. A lot of suckers now have a kind of a feature where you can turn the suction on and off with a little toggle, and so that can be helpful if you're trying to retract somewhere where you don't want to necessarily have that trauma of suction. And then just remember, the poorer the exposure planning, the harder the assistant has to pull on those retractors, and that can be, it can cause damage to the soft tissues with that as well. I think we've all had a retractor injury that we have looked back on and realized that we could have helped prevent. And this is the final slide. So I would just commend you all to practice. Going back to that initial slide of surgery as being a performing art, I don't think any of us would expect to, go out and buy a nice piano and play on it for a couple days and maybe get a lesson here or there and then expect to go play a concert. And I think a lot of times that's what we're expected to do with surgery is we are learning on the fly, but and there are certainly things that you can only learn in the OR, but it's not the right time to learn how to tie knots, for instance. And so you should be a skilled knot tire by the time you make it to the OR. So practice every day. For knot tying particularly, put gloves on, put gel on your hands. You're never going to tie with your bare hands in a patient, so you should practice with gloves on. There's some great resources out there. One I like to use is howardisms.com. There's great resources that can help you with some surgical techniques. Work on clamping and unclamping. Drive your friends and family crazy by constantly having a hemostat in your hand and clamping and unclamping and doing it with both hands so that you can practice using both hands. Practice with dull scissors. Try to make yourself work in some adverse situations so it's not a surprise in the OR. And then have a co-resident or friend keep you accountable. Ask you, how many knots have you tied today? What are you doing to practice your surgical skills outside of the OR? And then finally, make sure to take care of your hands. Don't take up woodworking as a hobby. Don't hang your hands out the car door window when you're going down the interstate, things like that. So take care of your hands. And hopefully this helps you guys and encourages you to keep working on your surgical skill.